Hey there, and welcome back to the Cycle Power Summit 2019. I'm your co-host, Melissa Buchan, and I am so excited about today's interview. Our guest is Dr. Phil Boyle, all the way from Dublin, Ireland. Dr. Boyle is founder and director of the Neo Fertility Clinic in Dublin. He is also president of the International Institute for Restorative Reproductive Medicine. He has over 20 years of experience in subfertility, and Dr. Boyle has helped over 3,000 women successfully achieve a pregnancy. Now, these are women who have previously experienced infertility, miscarriage, and failed IVF. This is really incredible work that he's doing. Now, you can learn more about Dr. Boyle's work at neofertility.ie. And I'm going to encourage you to also check out his new app, Neo Fertility. It's available on iOS and Android, and I have to say it's one of my personal favorites. Now, today's conversation is all about AMH, anti-Müllerian hormone, and some of its misunderstandings. Dr. Boyle, I'm really looking forward to today's conversation, so we're just going to get started.
Thank you, Melissa. So AMH, it's for, again, like you said, anti-Müllerian hormone. And there are pros and cons to the AMH. So what AMH is about is trying to identify a woman's ovarian reserve, or how many eggs she's got left. And this was, I suppose, developed to try and predict a woman's fertility better than we're currently able to do. So that was the whole purpose of it. But where it's most useful, in fact, is for IVF clinics. When they're trying to decide what stimulation protocol is going to be most effective to help them to get a dozen eggs in one single cycle, then if they know the AMH level, they have a good idea how much medication to give to get a woman to produce a high number of eggs. But when it comes to natural fertility, it's been poorly researched, and it's been misunderstood and misinterpreted to say, you're very close to the menopause. Look, you should do IVF quickly. Your AMH is lower than it should be for your age. But in fact, in recent times, more and more researchers are recognizing the main role for AMH is to identify stimulation protocols for IVF. But if you're trying to predict your natural fertility based on this blood result, you know what? We can actually do that. So it's good to put it into perspective. Now, it's not absolute, because you can have low AMH levels for your age. And this is where, with restorative reproductive medicine, we're developing new strategies for all of this. Because it is important. If your eggs are fewer than they ought to be based on that blood test, we would interpret that the majority of the time that a woman has a low egg reserve, it's because her immune system is attacking her ovary. Now, this is a new concept, and it's one that we work with clinically. And what we do is we apply immune modifying strategies to try and stop your body attacking your own ovary, so we can try and preserve your eggs, so that we can slow down the process of reducing the ovarian reserve. So for example, if I see somebody who is younger, not yet ready to have a family, then we will implement immune balancing techniques to try and preserve her future fertility.
Wow, this is a really interesting concept, this idea that so first of all, AMH is really misunderstood, and it seems to be a tactic for IVF specifically. So for those women who are interested in restoring their own natural fertility, they really don't need to pay much attention to it, give it much weight.
Yeah, and there is a bit of perspective to it, because at one point we weren't even doing the blood test. And then patients would discover the blood test exists, and then they would discover their number is lower than it should be. And oh my gosh, you never even tested for this. And it feels like you're somewhat negligent.
Okay.
And there is merit in knowing if it's lower than average, because then we know that this person really does benefit from immune modifying treatment, which will allow our hormone balancing to work better. So finally, we have come to the conclusion that we should probably test this and be more proactive with immune modifying treatments, but not be worried about their ability to produce one single follicle and get one good egg and achieve success. We've had success in situations whereby women are told, based on their AMH, you're not even suitable for IVF. Your AMH is so low, you're not going to get enough of your own eggs. The only way you're going to have a baby is donor eggs with IVF.
Wow.
And then they would come to us naturally and we go, yeah, but you still have a monthly cycle. You still have a peak day. You still have a temperature shift. And yes, your hormones are a little bit low, but you know what? We can actually optimize, balance, and improve that ovulation that you're already having. And incredibly, you may still be able to have a pregnancy naturally. And we've seen this for women with repeated failed IVF, even failed donor eggs, that we're still getting success naturally.
Okay, you've mentioned so much good stuff to dive into and get through. So I do want to talk about the immune modifying treatment and what your approach is. But before we get that, you're mentioning this term peak day. And so a woman feels like she has a diminished reserve, but she's still seeing a normal, healthy cycle pattern. Now, this is language that you and I know because we work in this field. But I think that most women, they don't even know what a peak day is or how to be able to identify that. So can you first speak to the importance of women knowing not only how to track when their period starts, but really diving into the details of their cycle? So let's talk about that first. And then I want to learn more about the immune modifying treatments that you take to treating your patients.
So the starting point is, like you said, track your period and see how frequently the cycle comes on. And many women just do that. Many couples that I would have coming to me would know, well, I get my cycle every 28, 30, 31 days, and some would keep a record of that. And many, that's as far as they go. Some are using apps that work on a calendar method, and they know where their menstrual period starts, and then the app does a calculation to say, well, we think you're ovulating around this time. And I would often ask, well, what signs are you observing to let you know you're ovulating? And they just go, well, it's a calendar calculation, and that is incredibly poor. And what a woman can do is she can look for specific signs of her fertility, and the key sign is cervical mucus flow. She notices the discharge on the tissue when she routinely goes to the toilet. And when there's visible mucus discharge, she could lift that off the tissue, stretch it between her thumb and index finger, and document how far does it stretch and what is the color. So it's a thing that once you get into it, you can really interpret and understand your fertility. And it's the last day of that discharge is presumed ovulation. Now, some women don't have that discharge and they just have a noticeable wet feeling while walking or moving. It's similar to what they notice around the time of the menstrual bleed, and they get that same sensation around the time of ovulation. And sometimes that is the key sign of fertility. So whether it's the wet feeling or the visible discharge, women can reliably identify this time of presumed ovulation that we call the peak day. And the peak day is the last day that she notices these fertile signs. So that would tell us that she's presumably ovulating at that time. And if she should get a menstrual bleed 2 weeks after that, and that would tell her she's correctly identified the peak day, unless she's actually pregnant and conceived for that cycle. So that's what the peak day is. And I'm sorry, there's another question you had for me there?
Yeah, absolutely. And we'll get to that. Okay, so ladies, for those of you who are listening, Dr. Boyle just took you through a whole lot of information. So listen to it again, take notes, but I'm familiar with his work. I know that he also has great YouTube video tutorials. So check that out as well. Something that Dr. Boyle says often is your chart is only as good as the data you provide. And so he took you through the detail. We could know a lot about our cycles, but first you have to know how to collect that data. So I just wanted to put that plug in there because that was really great information that you gave. But now that a woman can track her cycle and you're able to look at her data and evaluate the parameters of her menstrual cycle and really use it as a vital sign, can you talk a little bit about what you see and then how you treat it with, you use this term immune modifying treatments, and this idea that diminished fertility may be a result of our immune system attacking the ovary. This is really fascinating to me and I can't wait to learn more about it.
It's a new concept and it is more unique to our program with neofertility. But we have observed that if we apply immune modifying treatments, that we get better outcomes. And it's a beautiful, the main treatment that I use, first of all, is diet. And something as simple as eliminating high levels of dairy high levels of wheat. And for a lot of women, we're finding more and more that eggs are a problem food as well. So they're the three main ones. And then we also try to reduce down the fast sugars in particular. So we all know the fast sugars aren't good for us. But for example, if you're having your brown bread with a slice of cheese, a glass of milk, and your scrambled eggs, for some women, that is the worst mixture you could have with respect to your fertility. There is a blood test you can do where you look for IgG food antibodies. And if the blood test confirms that the antibodies are elevated, then it's clear which of those foods you should really avoid. So I'm keen that women don't go on incredibly strict restrictive diets because of excessive weight reduction will then impair your fertility as well. And my preference is, well, if you could do a blood test looking for these IgG food antibodies, Genova Diagnostics are a group who do it. The blood test is criticized a lot because there are a serious lack of publications. But despite that valid criticism, our clinical experience in doing the blood test and changing the diet accordingly has a very positive immune modifying effect. So it's a very simple immune modifying strategy. You reduce your antibody load and stop your immune system attacking your ovary to some extent simply by changing your diet.
Great. So from a practical standpoint, women who are listening to this, here you are in Dublin, Ireland, and somebody who's struggling in the United States with infertility, can they go to their doctor and say, request an IgG workup, or is the diagnostic something that I know there are a lot of order at home kits.
Yeah,
What is the
order it at home because the doctor will talk them out of it and tell them it's rubbish, sadly.
Okay, so an at-home kit.
Yeah, I understand where the doctor is coming from, so an at-home kit, yeah. But remember, there are a lack of publications and there are a lot of critics about this particular test, but the clinical experience is still very strong. So despite the lack of publications and despite your doctor most likely not being in favor of it, well, I'm one doctor at least who'd be inclined to recommend it, but do an at-home kit, yes.
Yeah, I'm happy to see that more and more doctors are getting on board with nutrition. Women, we know, we intuitively know that our diet directly affects how we feel and how our body performs, but it's getting that support. It's easy in theory, but it's very difficult in practice. So it's great to hear a physician who is backing up and saying, hey, you probably should take a very careful look at what you're consuming. This is all really good stuff. Okay, so if there is an allergy issue, they remove specific foods from their diet. What else about your approach do you take? You mentioned this multifactorial approach. So diet is one of them. Can you take us through the next level?
Yeah, so after diet, the next thing we look at is multivitamins. And you get a positive immune modifying effect if you get a good level of omega-3 and vitamin D3. And even if you live in a warm, sunny climate, you can often have a lot of factor 50, sunblock, and you're not out in it a lot. And all of a sudden you find you're actually vitamin D deficient. When you're low in vitamin D, you get immune dysfunction and immune problems. So top up with your vitamin D. And the other one is the omega-3 fish oils as well. And then folic acid for just routinely when you're trying to get pregnant. So this would be a basic for us, our diet, our supplements. And the third one is an outrageous one called low-dose naltrexone. So there is a good website, lowdosenaltrexone.org, and it explains all about this very inexpensive immune balancing treatment, not widely practiced, not widely known, but increasing in awareness, and it has great potential to treat premenstrual syndrome and to balance the immune system and have a positive effect on fertility. But everybody that I see with low AMH, invariably I recommend these things, the naltrexone, the supplements, and the diet. And then after that, then I look at the hormone balancing medications.
After that, the hormone. Okay. And so what are some of the hormone balancing medications?
So first step is track the cycle, pick your day of presumed ovulation or peak day, and then 7 days later, we get a blood test to measure progesterone and estradiol or estrogen levels.
And so that's the approach I'm familiar with, but you have a whole kind of precursory level before you even get to that.
Yes. So when we get the fertility chart and we get the peak day and we get the blood tests, then that could help us to decide, in addition to what we've started with diet, naltrexone, and supplements, do we need some hormone balancing treatment as well? I would say 8 times out of 10 we do when you're dealing with infertility or recurrent miscarriages. And that's where then you need a doctor who is trained in restorative approaches to try and restore optimum function to your cycle to improve the quality of your ovulation, which is also a radical new concept, because the current concept is, look, either you're ovulating or you're not.
Mm-hmm.
And we'd ask the awkward question, but what about the quality of your ovulation? And it causes a lot of confusion and head scratching, and fertility clinics saying, what are you talking about? You either ovulate or you don't. And we say, no, you could have a good ovulation or a poor ovulation. There is a way of interpreting that. And that's where our blood results would come in. And there are doctors trained in restorative approaches. Napper Technology is the original developer of all of this concept. But through the group that you mentioned, Restorative Reproductive Medicine, there are increasing numbers of doctors now taking this approach. And if we can interpret that somebody is having a suboptimal ovulation and correct that, then two things happen: quicker to get pregnant and lower risk of miscarriage.
Yeah, and I love this approach. I find this so very exciting. And from day one, when your first contact with a patient, you're working with them, helping them to understand their diet and their supplements. It can take time to confidently track your cycle and to be able to use that as an assessment tool. So in the meantime, while a woman's investing that time day to day, collecting the data, building that chart so that she can eventually identify that peak day and begin the hormone therapy, she's already done all of this work on adjusting her diet, taking the supplements. So I really love that from day one, when you're working with your patients, you can get them going and helping them to restore their overall fertility and health.
And what's really nice about that is, because we start with minimum treatment, so one of the big questions we're asking is, what are your premenstrual symptoms like? So the week before the period begins, do you get bloating, breast tenderness, mood changes? And some women feel incredibly unwell, especially for that week before the period begins. So we document that in advance. We implement these interventions with diet, supplements, naltrexone in advance of hormone balancing. And the majority of women come back super enthusiastic. Oh my gosh, those symptoms, they're gone. This is really, really good. And it's a nice confidence booster, even in advance of hormone balancing. And our concept is, we want you to feel good. We want your chart to look good. We want your hormones balanced. And then it might sound a little strange, but we want you to enjoy getting pregnant. This is not a stressed out, unpleasant chore, which it can be when people really get focused on the result. This is a project you're engaging in together, and you love each other, and a baby is more a fruit of your love, not your labor.
Yes.
So, and people have to be reminded about that, because they want the result so badly, they can lose sight of each other. So it's important that the context is emphasized and kept in the right balance as well.
Absolutely. Not to go down a rabbit hole, but stress can affect your cycle and a healthy ovulation in a very significant way as well. So,
which is okay. We all have stress from time to time, but this is where there's a triumph for the woman and the couple, where they go, look, I know what the stress was, and look what it did to my cycle. I'm going to take measures the next cycle to really minimize that type of a stress, so we won't get a cycle dipping like that again.
Oh, absolutely. You know, I've been charting for 15 years, and having 15 years of records, I can tell you I was part of the Hurricane Harvey flood in Houston, and I have my Hurricane Harvey cycle, and it was one for the textbooks for sure. For sure. Now let's look at some of the statistics that you have. So you are reporting that with your approach to subfertility and infertility, you have a 35% live birth outcome. And to really even take that further, these are all full-term pregnancies, and there were no twin pregnancies. So can you speak a bit to that? Because that's a really significant number when we look at infertility treatment.
Yeah, and in fact, we're actually 50% for your average couple, and the 35% is for these really difficult people. So that 35% that we're looking at would be from that recent data that I looked at, were for those with very low AMH, who have already, about a third of them have already tried and failed IVF, and the majority of them would be told, really, if you're going to have a baby, you're looking at donor eggs. So it's a particularly difficult subgroup we were looking at. And the average female age was 37 in that group as well. So for this group that are often told the prospects for IVF are poor for you, we're actually getting a 35% live birth rate. Now, half of them got pregnant, just a little over 50% conceived. And then we did 35% live birth rate. And these are real numbers. So we included there's a term that I use, it's called the early quitters, because we don't want people to quit the program early, but everybody who came to our program who was seen just twice, we included them.
Okay.
So in many ways, this is the most punishing way you can interpret our data, and we still got a 35%
Wow.
life
That's
rate.
really incredible.
Yeah.
Really incredible.
Yeah, and because it's a group that is particularly bleak otherwise, but because our egg requirement is one, we only need one egg. We do not need the half dozen. We're able to get there often where IVF can't.
Excellent. Excellent work. Excellent work. So as we are talking about a very difficult topic, and I'm just so inspired by the work that you're doing, what advice do you have for women who are struggling with infertility and they are having a hard time finding someone like you who takes this restorative approach? What can they do when they are not getting the support that they need?
Well, one of the first things, and it's a little bit of a plug for the work that I'm doing with the Neo Fertility app, but it is such a useful tool, and it's so accessible now because of getting access through through your mobile phone. You can get it for free for 3 months, and if somebody downloads that, we have a 10-minute explanatory video that explains, here's how you record everything with your fertility app. We'll start there. And then instead of just getting a lot of the calendar calculations that these fertility apps have, you're getting a biofeedback documentation of what your body is telling you about your cycle. And then if you go looking for restorative doctors, I think within the United States, the highest number of them would be trained in naprotechnology, that would be a real good starting point. The American Academy of Fertility Care Professionals would have a list of all the doctors that are trained in restorative approaches like naprotechnology. Now, they don't work with our Neo Fertility app, at least not, we haven't any formal agreement, but they would be able to interpret and understand a lot of the data that we've got there. We do recommend working with a fertility advisor as well, because you will find you can get a little bit lost. So somebody who's a trained fertility advisor or Creighton model practitioner is a massive support, because it leads to empowerment for the women where you understand and own your own fertility. And there's a really interesting book that was written by a woman who was on the verge of menopause. She was aged 42 and her FSH was 42. They weren't doing AMH blood tests at the time, but if they were, it would have been really very, very low. She was given bleak prospects by every fertility clinic she went to, but she had positive thinking, and she changed her diet. She looked after supplements, and that alone was enough to get her a successful pregnancy, even without the hormone balancing.
Excellent.
So,
And what's the book called?
Inconceivable.
Okay. I love books like this. I have a whole bookshelf of fertility and period related books. So I'm always looking to add to my list. And I love what you said there, mindset and diet. And mindset is so very important. I think that there's going to be some research coming out probably soon as the importance of mindset in our overall approach to dealing with this difficult struggle.
Yeah, and there's a guy called Mark Sherman who set up Organic Conceptions. Himself and his wife were 10 years trying to get pregnant. So they're late 20s and most of their 30s. And when they gave up, they got pregnant successfully twice. Every fertility clinic hears about this, and we all get frustrated by it, couples as well as doctors. But there's something in the surrender and acceptance that really helps couples to get pregnant. So he's doing a lot of good work on the psychology of conception, and that's something that people could look at as well.
Absolutely. I should backtrack and say the research has been done. And actually, Mark is one of the co-hosts for the summit. So we'll be hearing a lot about him and learning about the work that he does in this journey. But yeah, he's done fantastic work. And you partner with him. You offer his program to your patients, correct?
Absolutely. And there's two angles to Mark's work that I really like. First of all, I think he's very genuine about what he's doing. It's born out of lived experience, and he knows that psychology makes a difference. And every clinic knows that, but we don't quite know how to tap into that. Mm-hmm. So I expect we will be able to do better by helping people to recognize the kinds of stresses that are involved with all of this. But we, as a Neo Fertility, we invest in his program. we pay him a monthly fee so that every couple that we're actually working with, we give them then complimentary access to the organic conceptions materials. But we're actually, we pay for it through our own program because number one, it should help people to get pregnant. But number two, if we're at the point where we try, and this doesn't work, if a couple have moved to authentic surrender and acceptance, to be able to live with that really matters, and they help people with that as well. So, because the reality of fertility treatment is you're never going to be 100%, but to have people at a point of wholeness and connectedness and being able to move on with it, it's like bereavement. Nobody likes bereavement, but it is a fact of life. So having surrender and acceptance and learning how to live with that is important as well if we're not able to get the ultimate result.
Yeah. Yes, absolutely. Dr. Boyle, thank you for helping us recognize, as you call this multifactorial approach to dealing with infertility and reproductive health. And I always get so encouraged in engaging in conversations with you and doctors who take your approach. I'm very fortunate here in Houston to have a group of doctors who are supportive of this type of work, and it's just a beautiful thing. But I think the majority of women do not find the support. So that is our whole goal here at the Cycle Power Summit, is to really get this information out and know that doctors are supportive of women. They want to get to the root cause and help develop this multi-leveled approach to restorative health, restorative reproductive medicine. It's a beautiful, beautiful thing. So as we conclude, oh, go ahead. Did you have something to add?
I was just going to say, it's down to getting good data. So the onus is on the doctors who are working in this area, where we have plenty of clinical experience. Please God, once we get the data together, we make a solid scientific argument and say, there's the data. And then doctors with different opinions, it's not down to anybody's opinion and say, well, there's what the data shows. So as we work more and more on this and get more and more doctors cooperating, the data should speak for itself. And then I do expect larger numbers of doctors will have to follow this route because the data would back it up.
Yeah, and that's something that listeners, all you ladies, you can be the grassroots movement on that. If you find a good cycle tracking app, and again, I'm going to put that plug in for Neo-Fertility app because it's a good one. But if you collect the data yourself, first you have to know how to chart well. Chart well, collect the data. Take it to your doctor. If they see more and more women showing up in their office with this data, they're going to start listening. So I think it does begin at this grassroots movement, but I think we're well on our way. Very exciting stuff. Okay, so Dr. Boyle, what is your number one cycle power tip that you could offer women today?
It's got to be track your cycle, just like you said, and that become informed. Don't just simply put yourself in the hands of your regular gynecologist and say, let's see what they advise. Very, very quickly, you're told this can't happen. You're told no. You're told never. You're told hardly ever. And understand, my take-home pearl is, if it's not happening, if you're not getting pregnant, or if you're having miscarriages, there has to be a reason. And our whole approach is, we search, we dig deeper. It's rarely single issue. It's usually multiple factors all working against you at the same time. And the more factors we find and correct and fix, the better the chance you're going to get success. So my thing is, there has to be a reason. Find what the reason is. Educate, empower, learn how to track your cycle, and understand what you're doing and why you're doing it. And I think that, and also remember to love each other along the way.
Yes. Yes, you have to give yourself a little grace. Absolutely. Well, this has been so educational and informative, and I just always enjoy having the opportunity to speak with you. So thank you so much again, and we look forward to hopefully continuing to hear about the work that you do with Neo-Fertility and watching your successful practice grow.
Thank you, Melissa. Much appreciated.